Hello everyone, my name is Nina Bondarenko and today I'm going to talk with you about so interesting and sophisticated topic like oncology, and my lecture is about introduction to oncology. So let's begin. Cancer is the second leading cause of death in the world and the only cardiovascular diseases exact at higher toll. Even more organizing than associated mortality is emotional and physical suffering infected by neoplasm. There are main features of the cancer, and I guess you know that cancer is a genetic disorder caused by DNA mutation. Genetic alteration in cancer cell are heritable, being passed to daughter cell upon cell division. As a result, cells harboring this alteration are subject to Darwin's selection. When, as you know, survival of the fittest. Mutations and epigenetic alterations impact cancer cells, a set of properties that are referred to collectively as cancer hallmarks. We will discuss these hallmarks a bit later during the lecture. This slide indicates the most common cancer expected to occur in men and women. Among men, cancer of prostate, lung and bronchus, colon and rectum together account for more than 56% of all newly diagnosed cancer. As you see, among females, breast cancer, lung and colon rectum either take a crucial role in the cancer morbidity and mortality. So, now we are ready to give definition. Definition of cancer or neoplasia. Neoplasia is a type of abnormal or excessive growth of tissue. The growth of neoplasia is uncoordinated with that of the normal surrounding tissue, and it persists growing abnormally, even if the original trigger is removed. Abnormal growth usually, but not always, forms a mass. When it forms a mass, it may be called a tumor. So we have different names of almost one entity. When we are talking about new growth, we usually use term neoplasia. If this new growth form mass, we use term tumor. And if we mean that tumor has malignant properties, we use cancer. So be attentive. There are most common cancers that you can find among children, like acute lymphocytic leukemia, CNS malignancy, neuroblastoma, and non-Hodgkin's lymphoma. We know different carcinogenic agents, like chemical carcinogens, direct acting chemical carcinogens, or indirect acting chemical carcinogens. Either we know lot of examples. For instance, nitrosamines responsible for the gastric cancer, cigarette smoke, multiple malignancies. I guess you can name at least several of them. Polycyclic aromatic hydrocarbons responsible for the bronchogenic carcinoma, and a huge amount of different other carcinogens with chemical nature responsible for the cancer growth. Either we know physical agent like radiation, particularly ultraviolet B sunlight, skin cancer may develop as a result of this, and you know that for protection you should use protective sunscreen cream. Ionizing radiation also may be a reason of cancer growth and progression, like X-ray, gamma rays, alpha, beta particles, protons, neutrons, and different variants of leukemia and thyroid cancer may be a result of this injury. Uranium miners responsible for increased lung cancer incidence. Not only chemical and physical agents may be responsible for the cancer growth. Either we know oncogenic viruses. There are several RNA oncogenic viruses like human T-cell leukemia virus and from the name you can suspect that this virus is responsible for the T-cell leukemia or lymphoma. And different DNA viruses include the following, like hepatitis B virus, that's responsible for hepatocellular carcinoma, Epstein-Barr virus, responsible for Burkitt lymphoma, B-cell lymphoma in immunosuppressed patients, and even nasopharyngeal carcinoma. Human papilloma virus either may be a reason, and I guess you know that human papilloma virus can be a reason of variety of carcinoma of different localizations like cervical, vulvar, vaginal, penile, and anal. And Kaposi sarcoma associated herpes virus type A, which cause Kaposi sarcoma. So we know another variants of carcinogenic agents like loss of immune regulation, and we know that patients with immune system dysfunction have an increased number of neoplasms, especially malignant lymphomas. Okay, now it's time to talk about molecular basis of cancerogenesis. Cancerogenesis is a multi-step process that characterized by accumulation of non-lethal genetic damage. A tumor is formed usually by the clonal expansion of single precursor cell, monoclonal, and we know 4 classes of normal regulatory genes. And as you can understand, mutations and changes that occur in these groups of genes may be responsible for the cancer progression and cancer growth. So there are many of them. Proto-oncogenes. Proto-oncogenes, normal genes that encode cell proliferation, cell growth, and may code proteins, different proteins. Anti-oncogenes, usually responsible for the growth suppression. Either we know a lot of genes that take a part in DNA repair and apoptosis regulatory genes. So, in which way may develop carcinogenesis? For example, due to activation of growth-promoting oncogenes. So, once again, proto-oncogenes, normal genes responsible for growth and cellular differentiation. Oncogenes derived from proto-oncogenes by, first, a change in the gene sequence resulting in a new gene product, oncoprotein, or a loss of gene regulation resulting in overexpression of the normal gene product. So, as we can see, oncogenes is derivatives of proto-oncogenes that can characterize or overexpression of some normal genes, and as a result of this overproduction of gene product, or change of the gene sequence and generation of new gene product that we name like oncoprotein. So there are a variety of the clinically important oncogenes. Just for instance, for example, FGFR3 and FGFR4 is the famous oncogene that usually can be revealed in the cancer of stomach, breast, bladder, and Kaposi sarcoma. And due to overexpression of this oncogene, may be released a lot of growth factors, fibroblast growth factors that will be responsible for the cancer progression. The same with, for example, ERBB1 in squamous cell carcinoma is the overexpression responsible for the overexpression of epithelial growth factor receptors that's sensitive to the growth factors, and different other variants that you can analyze later during preparation to the practical class. Second mechanism of carcinogenesis connects with activation of tumor suppressor genes. Tumor suppressor genes encode proteins that regulate and suppress cell proliferation by inhibiting progression of cells through the cell cycle. As example, p53 prevents a cell with damaged DNA from entering in S phase, while retinoblastoma RB gene prevents the cell from entering cell phase until the appropriate growth signal are present. Another group of genes that's responsible for DNA repair, also very important in anti-tumor growth protective mechanisms. But if as a result of endogenous or exogenous agents develop DNA damage, different epigenetic alteration may be responsible for the lack of DNA repair function. We receive DNA repair deficiency and large increase in unrepaired DNA damage responsible for large increase in somatic mutations and epigenetic alterations, multiple altered field defect with driver mutation. As a result of this, responsible for progression to the cancer. There are different important suppressor genes that may take a part in cancer progression either. What else should we discuss? Regulation of apoptosis. We know different genes responsible for the apoptosis regulation, and accumulation of neoplastic cells may result due to mutation in the genes that regulate apoptosis. For example, BEX, BET, BCL, and BID. Mutation of genes resulting in evasion of apoptosis. There are BCL2, P53, and MYC. So, which mechanisms either responsible for the carcinogenesis? Limitless replication, that possible due in part to upregulation of telomerase. Sustained angiogenesis is possible due in part to activation of Notch signaling pathway. Invasiveness, metastasis. Malignant cells must dissociate from tumor, and as a result of this, you can find loss of adherent function and degrade the extracellular matrix before spreading to the distant site. Cancer-associated lichens and being investigated for their role in cancer spread and as target for the therapy. There are 8 cancer hallmarks and 2 enabling factors like genomic instability and tumor-promoting inflammation. Most cancer cells acquire these properties during their development, typically due to mutations in critical genes. So let's list all of them. Avoiding immune destruction belong to the cancer hallmarks. Evading growth suppressors, enabling replicative immortality, tumor-promoting inflammation, activating invasion and metastasis, genomic instability, inducing angiogenesis, resistant cell death, deregulating cellular energetics, and sustaining proliferative signaling. All these 8 hallmarks very crucial for the cancer progression and cancer growth. So, my question: how do tumor cells escape immune surveillance? There are several mechanisms of immune surveillance. Mutations like microbes, persistent mutation, hiding of major histocompatibility complex molecules on tumor cell surface, lack of CO stimulation molecules, immunosuppressive agents, antigen masking, apoptosis of cytotoxic T cells, the cells that's responsible for the tumor killing. And now I wonder, do you know who was awarded the 2018 Nobel Prize in Physiology and Medicine? Yes, these two very famous now scientists were awarded with Nobel Prize in Physiology and Medicine. And now question, due to what? They were awarded because they discovered CTL4 and PD1 mechanism of immune response during the cancer growth. PD1 receptor is highly expressed by activated T cells, B cells, and natural killer cells. The well-known ligands of PD1 are PDL1 and PDL2. And what is interesting that PDL1 is expressed in macrophages and can be induced by inflammatory cytokines on tumors, immune cells, and various tissues. After ligand binding, PD1 inhibits kinase signaling pathway involved in T cell activation. Thus, this process prevents overstimulation of immune response. PD1 primarily inhibits T cell activity in the effector phase within tissues and tumors, whereas CTL4 regulates immune response early in T cell activation. Therefore, PDL1 and PD1 axis blockade should enhance anti-cancer immunity. So, antibodies direct against CTL4 and PDL1 pathway have been demonstrated to be effective treatment strategies which induce durable tumor response in patients with various malignancies. Response rate in nivolumab monoclonal antibodies, and the end right of this term, were 18% in non-small cell lung carcinoma, and 28% in melanoma, and 27% in renal cell cancer. So now let's talk about predisposition to the cancer. What about the geographic and racial factors that take a part in the cancer progression? So we know, for example, that stomach cancer is much more prevalent in Japan than in the United States. Breast cancer is much more prevalent in the United States than in Japan. Liver hepatoma is much more prevalent in Asia than in the United States, and prostate cancer is more prevalent in African Americans than Caucasians. We either know that hereditary age and sex either take a part in the cancer rate. Genetic predisposition. There are several familiar cancer syndromes that characterized by a set of features like early age of onset, two or more primary relatives with the cancer, soil theory, multiple or bilateral tumors, and there are main examples of genetic familiar cancer syndromes like retinoblastoma, familial polyposis coli, neurofibromatosis, multiple endocrine neoplasia. Age either take a crucial role in cancer growth. Most cancers occur in persons that are older than 55 years, but as well we know childhood cancers like leukemia, CNS neoplasm, and bone tumors. Gender also very important in the rate of different variants of cancer. But what about the non-hereditary predisposing conditions? To be honest, at this moment, I guess you heard about a lot of them because during the previous topics you studied such changes in the cells, like adaptation, or maybe like an answer on the injurious factors, like dysplasia. Nowadays, we usually use term squamous intraepithelial lesion or squamous intraepithelial neoplasia, and carcinoma in situ, cervical squamous intraepithelial lesion. And these lesions characterized by changes in cell size and shape. I will show you later what does it mean when you analyze microscopic slide. Metaplasia, as you remember, transformation of one type of tissue, usually epithelial tissue, into another, like Barrett's esophagus, squamous metaplasia of the bronchial mucosa. Either with no oral leukoplakia, endometrial hyperplasia, chronic inflammation. So all these conditions may be pre-malignant, maybe like, transitional condition between non-malignant and malignant condition. Some benign tumor may with time progress into the malignancy, like neurofibromatosis, pleomorphic adenoma, multiple adenomas of the large intestine. And miscellaneous conditions like chronic ulcerative colitis, atrophic gastritis, cirrhosis of the liver, and chronic bronchitis in heavy cigarette smokers. Either we know that hormones can be a trigger factor for the cancer growth, and in this case we should to say about estrogen, contraceptive hormones, and anabolic steroids. And as a result of this may develop hormone-dependent tumors. Let's talk in details what does it mean squamous intraepithelial lesion or dysplasia or squamous intraepithelial neoplasia. Literally means a loss in uniformity of individual cells and in their architectural orientation. In dysplasia, some but not all of these features of malignancy are present microscopically. And now look, dysplasia may develop into malignancy in such organs, for instance, like uterine, cervix, colon, polyps. Usually a seal or dysplasia can be graded as low grade or high grade, often prompting different clinical decisions. Dysplasia, look, may not develop into malignancy. So as you can see, dysplasia may be reversible. And this is a very important clinically. High-grade dysplasia often can be classified with cancer in situ. So there is a classification of dysplasia or squamous intraepithelial neoplasia or lesion. And as I mentioned above, we have different grades of dysplasia, heavy dysplasia or high grade. We number like grade 3. And mild or low grade dysplasia, right, like grade 1. During the grading of the dysplasia or squamous intraepithelial lesion, you should estimate thickness of the abnormal atypical cellular appearance, cellular atypism. So if the epithelial cells with different shape of the cellular body and size, we name it like pleomorphism, present in the lower third of the epithelium, we usually classify it like grade 1 dysplasia. If 2/3, grade 2, 3. If entire layers of the epithelium is changed, in this case you can classify it or like grade 3 or like carcinoma in situ. And with time, as you can see, next station is microinvasive carcinoma, when these invasive cells, neoplastic cells, pass through the basement membrane and invade subepithelial stroma. So this is an example of squamous intraepithelial lesion. In this corner you can find normal squamous multilayered epithelium stratified, and this is squamous intraepithelial lesion, third grade with severe dysplasia. Note that dysplastic basal cells characterized by a cuboidal shape, high nuclear cytoplasmic ratio, hyperchromatism, mitotic activity even, and some of epithelial cells show us loss of orientation to the basement membrane, occupy the lower 2/3 of the surface rather than just the basal row of cells. So, due to this fact, we can conclude that we work with squamous intraepithelial lesion, second, third grade. So this is mitotic figure, I guess, and hyperchromatism means dark nucleus. Pleomorphism means different shape and size of the cells and nucleus. What else can we find? We can find maybe prominent nucleoli here, and all these changes develop in 2/3 of the entire epithelium. So once again, compare with normal epithelium, quite different. Do you agree? So this variant is described carcinoma in situ. And what we can see dysplastic basaloid cells here, really blue epithelium, right? If you will compare with normal, you can recognize that nuclear size quite higher in the size, no, bigger in size than normal epithelium nucleus, and all these changes develop in the entire layer, entire epithelium. What else can I find here? I can find mitotic figure, prominent nucleoli, maybe some lymphocytes that infiltrate this epithelium, and really inflammatory reaction from the really prominent inflammatory infiltration from the subepithelium stroma. But what an important here, I see integrity of the basement membrane. So basement membrane present, and all changes that occur in the epithelium develop above basement membrane. That's why for this case we use term carcinoma in situ, instead invasive carcinoma. So this is a crucial distinguished feature between these two different stages of the cancer progression and growth. So now let's analyze nomenclature. In which way should we name different types of the tumor? And in this case you have to be attentive. If you would like to name benign tumor, you just should add at the end of the word suffix oma, and you receive benign tumor. But there are some exclusions for such terms like carcinoma, sarcoma, lymphoma, seminoma, and melanoma. So all these five terms, five entities, are strictly benign, or strictly malignant. Strictly malignant. For all other issues, it's almost all the time works. For example, if you would like name mesenchymal tumor means tumor that arises from the mesodermal layer during embryogenesis. I mean that mesenchymal tissue arrives from the mesoderma during embryogenesis. And if our tumor arises from this mesenchymal type of tissues, we may add suffix oma, and in this way receive such variants of benign neoplasia like chondroma, fibroma, for example, osteoma. If we are talking about epithelial tumors, we know that epithelium during embryogenesis arrives from the ecto and entoderma. We either may use suffix oma, but in this case be attentive, because we know two different variants of epithelial tissue, like glandular epithelium and epithelium that usually cover or line our cavities or cover our body. So for this case we should use just suffix oma. So once again, glandular epithelium require a tumor that arises from the glandular epithelium require adin and oma, adenoma as a result, while benign tumor that arises from the conventional epithelium just require suffix oma. Papilloma Tumor with finger-like projections like papillary cyst adenoma, papillary and cystic tumor forming glands. So this part of nomenclature AD tell you, it's like a tip for you, tell you about glandular nature and origin of the tumor. And oma means tumor mass. Polyp is a tumor that projects above a mucosal surface. And this moment I want to remind you some another moment. Do you remember during the topic inflammatory reaction, inflammation, you studied such specific variant of chronic inflammation like granuloma, and I discussed with my students that please be attentive, don't confuse with tumor. Granuloma, such term we use because chronic inflammatory reaction appears like nodule, and this similarity was the main reason why we use such term like granuloma. So with the same end, with the same suffix oma, but the nature of this lesion is inflammatory reaction. So granuloma is inflammatory reaction, and despite the suffix oma, while different other variants usually characterize tumor growth. So this is colonic polyps. Gross appearance of several colonic polyps that also you can call like adenoma. Sometimes in the colon you should name it like tubular adenoma, sometimes adenomatous polyp, sometimes villous adenoma, but the correct name you may set after the microscopic investigation. So this is either papillary adenoma of the colon. In this case we add first word like papillary. Why? Because we can recognize finger-like projections of the tumor. That's why papillary adenoma. This slide shows us colonic polyp or tubular adenoma. This benign glandular tumor is projecting into the colonic lumen, and it is attached to the mucosa by distinct stalk. Okay, now it's time to talk about malignant tumor, and in this case the nomenclature a bit more tricky. For the mesenchymal tumors means tumors that arise from the mesenchyma. You should use term sarcoma only sarcoma. Let me remind you main tissues that arise from the mesenchyma. There are cartilage, bone, synovial tissue. For the tumors that arise from the epithelium, we usually use term carcinoma, and in this case you also should be attentive, because for the tumors that arise from the glands and gland-forming tumor, we name like adeno, once again carcinoma. For tumor with squamous differentiation, we usually use combination like squamous cell carcinoma. For cancers that doesn't show us any differentiation, we can use term undifferentiated sarcoma. And note that carcinoma can arise from ectoderm, endoderm, or less likely mesoderm. This slide is a transitional zone from normal squamous epithelium and invasive carcinoma. So you can see nests of squamous epithelium where in the subepithelium connective tissue, so in this case in the derma. In the derma you can find a lot of squamous epithelium nests. So this is sign feature of the invasive carcinoma. We know such classification like grading that characterize the level and the level of differentiation of the tumor. This slide shows you well differentiated. squamous cell carcinoma, and the nests invading cells still attempt to make keratin, which then gets disposed in the center of the nest, resulting in keratin pure. Still, in squamous carcinoma usually means level of differentiation. This is another slide that shows you invasiveness of the cancer with squamous differentiation and visible intercellular bridges also present here, and look prominent inflammatory reaction in the sub-epithelial stroma in the derma. This is adenocarcinoma, and you can find glands in the tumor mass, and usually this, in particular this case, adenocarcinoma is a result of malignization and progression of the ulcerative colitis. This is lymph node with undifferentiated large cell carcinoma of the lung inside, so this is a result of metastasis. So we continue our nomenclature of the tumor, and we know tumors with mixed differentiation. There are pleomorphic adenoma of salivary gland or even carcinosarcoma. Either we know such entity like teratoma, this tumor comprised of cells from more than one germ layer, arise from totipotent cells, usually gonads, and benign cystic teratoma of ovary, the most common teratoma. Either we know tumors with aberrant differentiation like hamartoma or hariastoma in misnomers. For example, as I told you previously, hepatoma, despite the just suffix oma, is a malignant liver tumor, as well as melanoma, skin tumors, seminoma, and lymphoma. So all these tumors are malignant. This slide is gross appearance of an opened cystic teratoma of the ovary. Note the presence of hair, sebaceous materials, and even tooth. You don't need a microscope at this level to appreciate the tumor. Produce both connective tissue as well as epithelium-derived elements. So that's why this is teratoma. This is dermoid cyst of the ovary, benign cystic teratoma. You can find epithelium, glandular material here, and that's why this is dermoid tumor. These tumors show us sebaceous gland, here respiratory epithelium, here bone and even bone marrow. So we either may conclude that this is teratoma. So let's sum up nomenclature of the tumors, and we classify according to the tissue origin. We know epithelial tumors, we know non-epithelial tumors, mixed tumors, and tumors of more than one germ layer. Each of this group we split up on benign and malignant subgroup, and for different variants use different suffix, but the common suffix for all of them is suffix oma. But for benign we just use suffix oma. For malignant, if this is epithelial nature of the tumor, we use carcinoma. If they are mesenchymal, sarcoma. So let's compare benign and malignant neoplasms. So there are main general features of benign versus malignant neoplasms. And when we compare, we usually estimate this tumor on two levels. Gross level, macroscopically, and micro level, microscopically. So benign tumor are usually characterized by small size, slow growing, and encapsulated or well-demarcated borders. While malignant tumor usually larger than benign counterpart in size, characterized by speedy rapid growth, Usually macroscopically you can find areas of necrosis or hemorrhages, and usually this tumor, malignant cancer, characterized by poorly recognizable borders, poorly demarcated. When you reveal and analyze this tumor macroscopically, it's time to analyze it under the microscope. For this reason, you take a piece of this tissue, we name it like biopsy, and prepare slides for future analysis, following analysis. So microscopic features of the benign tumor include expansive growth with well circumscribed borders. Either you can find that these cells that belong to the tumor may be well differentiated, means appear like mature normal tissue from which this tumor arises, resemble the normal tissue counterpart from which they arise, and non-invasive and never metastasize. While malignant tumor vary from well to poorly anaplastic differentiated form, tumor cells vary in size and shape. We, for this description, use the term pleomorphism. Increased nuclear to cytoplasmic ratio means you will see a large sized nucleus with tiny cytoplasm at the periphery of the cell. And either you can find high mitotic activity with abnormal mitotic figures, invasive growth pattern, and certainly malignant tumor has potential to metastasize. So this is comparison between benign and malignant counterpart of tumor that arise from the smooth muscle cells, smooth muscle tissue of the uterus, means from the myometrium. So for the benign tumor we use term leiomyoma, and look on even on this schematic slide you may recognize all key features of the benign tumor. This tumor small, well demarcated, that means that you easily may recognize border of these tumors, with slower growing, non-invasive, no metastatic, and well differentiated, means microscopically these tumor cells appear like normal smooth muscle tissue. While malignant cancer, malignant tumor that we name like rhabdomyosarcoma for this case, usually larger in size, poorly demarcated, so you can't recognize easily the borders of this tumor, characterized by rapid growth with hemorrhages and necrosis in the tumor mass, and locally invasive, metastatic, and poorly differentiated. Look, even on this slide you can recognize that all cells are different. Absence of uniformity of the cells that usually can be present in the normal mature tissue. So usually you compare and estimate the rate of growth, cancer phenotype and stem cells, clinical and growth features, microscopic features, spread of tumor, local invasion, like subtype, and metastasis or distant spread. Clinical and growth features, borders, surrounding tissue, size, and secondary changes. Secondary changes, once again, presence or absence areas of hemorrhages and necrosis. As you remember, secondary changes is a feature of malignancy. Growth of tumor. We know expansive and infiltrative type of growth. Infiltrative type of growth, usually characterized by invasion, diffuse invasion of the cancer cells into the surrounding tissue, while expansive growth, usually characterized by pushing of the normal tissue by the tumor mass. So expansive growth is usually a feature of the benign tumor, while infiltrative growth is a feature of malignancy. Either we know exophytic and endophytic growth. Exophytic growth means growth into the lumen of the organ like he. Endophytic growth characterized by growth into the organ wall. There are different variants of the tumor, like node, like infiltrate, like ulcer and cyst. There are different microscopic features of the tumor, and when you analyze microscopically neoplasia, you should estimate microscopic pattern, histomorphology of neoplastic cells, if these cells differentiated or not, tumor angiogenesis, and inflammatory reaction. Differentiation. We know different stages of cell of neoplasia differentiation. Well-differentiated neoplasm means that this cell resembles mature cells of tissue of origin. Either we know moderately well-differentiated to well-differentiated neoplasm, poorly differentiated, composed of primitive cells with little differentiation, and even anaplastic neoplasia, where anaplasia means lack of differentiation and is a characteristic feature of most malignant tumors. We either know that some correlation between the level of differentiation with biological behavior of the tumor. We know that benign tumor are usually well differentiated, while poorly or anaplastic tumor are usually characterized by worse prognosis than well differentiated malignant tumor. Look on this slide. This slide is about the myoma of the tumor. Of the uterus, the type variant of tumor growth is a nodule, and if you will take piece of this tumor and analyze microscopically, you receive well-differentiated cells interlacing bundles of the neoplastic smooth muscle cells that are virtually identical in appearance to the normal smooth muscle cells in the myometrium. These cells, let's say, looking good. Looking good means looking like the cells they supposedly arose from. This is well-differentiated squamous cell carcinoma of the skin, and the tumor cells are strikingly similar to the normal squamous epithelium cell with increased intracellular bridges and nests of the keratin. So we see invasive growth, but at the same time we may recognize that this is epithelial cells. So in this case we should use classification that describes this cancer like well-differentiated squamous cell carcinoma. Anaplasia. What is that? Anaplasia means lack of differentiation, and anaplasia means cellular atypism, and anaplasia usually is a feature of the cancer. There are several key moments, key points that belong to the term anaplasia. So anaplasia characterized by pleomorphism, means variation in size and shape. Hyperchromasia means dark, well-stained nucleus of the cells. High nuclear cytoplasmic ratio. Presence of giant cells. Abnormal nuclear morphology. And the nuclei will be variable and bizarre in size and shape. Either you can find prominent nucleoli, mitotic figures, both, like normal and atypical, and loss of polarity, functional cytoplasmic changes, and chromosomal abnormalities. So let's analyze this anaplastic tumor of the skeletal muscle. For this tumor we use term rhabdomyosarcoma. Note the marked cellular and nuclear pleomorphism, hyperchromatic nucleus, presence of the giant cells. So all features of anaplasia of cellular atypism prominently present on this slide. This is anaplastic tumor, shows you either pleomorphism, so all cells are different in shape and size, and even I can find here figure of mitosis, but I can't classify which stage is that, prophase, metaphase, anaphase, or telophase. That's why I conclude that this is atypical mitosis, a typical feature of mitosis that either belong to the anaplastic characteristic of the cancer. This is anaplastic large cell carcinoma of lung, showing cellular and nuclear variation in size, shape, No differentiation into squamous or glandular epithelial is evident. This is what we mean when we say it looks bad. Definitely. So these cells pleomorphic, hyperchromatic. This is a classic image of tumor in which any pathologist would call malignant, because it's obvious that this tissue, this tumor, very malignant and anaplastic. What either belong to the characteristic of anaplasia, loss of nuclear polarity. So look, this is normal epithelium. We can find that all nucleus near the basement membrane, while during the cancer growth you can find loss of nuclear polarity. So nucleus are present at the apical part of the epithelial cells. This slide describes pleomorphism, anisonucleosis, increased nuclear cytoplasmic ratio, nuclear hyperchromatin, and prominent nucleoli. So this is prominent nucleoli. High nuclear cytoplasmic ratio means large nucleus with tiny cytoplasm at the periphery. Mitosis, anisonucleosis means different shape and size of the nucleus. Pleomorphism, shape and size of the cell body. And nuclear hyperchromatism. Mitotic figures, as I promised you, we know normal mitotic figures like bipolar and abnormal with different shapes of mitotic figure. If simplify explanation, if you can't recognize which stage is this, prophase, metaphase, or something else, you should use term abnormal mitotic figure. This is giant cell in osteosarcoma, also a feature of malignancy. And look on it. This is fibroadenoma of the breast. How can I describe this tumor? I can recognize quite easily nodule with capsula on the periphery. So as you remember, well recognizable borders, small size is usually features of the benign tumor. So that's why, taking into account the localization, breast, you may predict that maybe you work with benign tumor that we name like fibroadenoma. But let's analyze this piece of tissue, piece of tumor microscopically. What can we see here? We see capsula on the periphery and a tumor nodule that consists of the stroma plus glands. Stroma part you should name like fibro, glandular part you should name like adene, and we know that this is new tissue mass, means tumor. That's why we have to use at the end oma. So now everything is suited to each other. We work with fibroadenoma of the breast. Look on this slide, something is changed. I see some whitish dense material, dense tumor in the middle, in the center of this gross specimen. And what I can't recognize borders of this tumor. I see invasive borderline of the tumor. I can't see capsula, so it's crab-like appearance of the tumor mass. And under the microscope, microscopically, I see invasive, infiltrative growth, lot of neoplastic malignant cells that invade surrounding tissue without any borders, without any capsula. So that's why I may conclude quite easily that in this case we work with adenocarcinoma of the breast. This slide either is about adenocarcinoma of the breast, because you can see this blue colored area is low, at the low magnification is epithelial glandular cells that invade surrounding tissue, and even you can see adipose tissue in the close to the invasive carcinoma of the breast. So there are very specific characteristics of the invasive carcinoma. So what we have? We have primary tumor, primary cancer somewhere in the body. But we know that one of the main ability of the cancer is the ability to spread. Spread means give secondary metastasis somewhere in the body. We know that cancer may spread locally, and we name it like local invasion of direct spread. Local invasion can be in the capsula of the organ or in the basement membrane. In the capsula, not even of the organ, in the capsula of the pre-existing benign tumor, for example, follicular adenoma of the thyroid gland, usually characterized by presence of the capsula, but if with time we receive transformation of this adenoma into the malignant cancer, we may recognize invasion of the malignant tumor in the capsula of the pre-existing benign adenoma. But not only local invasion characterizes the malignant tumor, but also distant spread. And distant spread we name like metastasis. The opportunity to metastasize, means give metastasis, is a key feature of the cancer. And we know three main routes of spreading, like lymphatic, hematogenous, and seeding of the body cavities. This slide describes us mechanism of the biology of invasion and metastasis. Look, this first stage shows us primary tumor, and with time between these primary cancer cells may develop loosening of the tumor connection due to decreasing of E-cadherin protein on the surface of the cancer cells. And either with time may develop in the tumor mass aggressive clone with angiogenesis and loosening of the tumor cells. After that, tumor cell and epithelial extracellular matrix interaction develop to the degradation of the extracellular matrix, and in this case our cancer cells may spread through the extracellular matrix and invade entry in the lumen of the vessel, and form something that appear like thrombus, but this thrombus consists of the neoplastic cells and covered by platelets, lymphocytes, and proteins like fibrin. But after that, when this thrombus mass detach from the endothelial surface, they form tissue emboli, and these emboli may migrate through the circulatory system, and somewhere in the circulatory system may develop extravasation of the tumor cells and formation of the distant metastasis. Lymphatic spread is the most common variant of cancer spreading, and in general carcinomas metastasize by lymphatic route, while sarcomas favor hematogenous route. We know two variants like lymphatic permission and lymphatic emboli. Nota bene that work of lymph nodes is nodal metastasis, preferentially to supraclavicular lymph node from cancer of abdominal organs, for example, cancer of the stomach, colon, and gallbladder. Okay, this slide describes regional nodal metastasis during different cancers, different sarcomas. For example, cancer breast usually spread in the regional lymph node, sentinel lymph node, in the axillary area, while cancer lung usually spread in the either sentinel lymph nodes, paratracheal or parabronchial group. In which way? Through the efferent lymphatic vessels, these malignant cells may accumulate firstly in subaxillary sinus and after that in the central part of the lymph node. This slide is describing metastatic sarcoma of the lung. You can see large whitish colored dense lymphatic nodules with lot of foreign tissue, and this tissue is epithelial tissue. I'm sorry, not epithelium, is a sarcomas tissue that infiltrate these lymphatic nodules. So in this case, we are talking about distant metastasis, distant spread of the lung sarcoma. For sure, these changes in the body is a sign of adverse prognosis for the patient. This lymph node with metastatic adenocarcinoma, how do I know it? Because I see at the periphery remnants of the lymphatic nodule. I see lymphatic tissue, lymphocytes, and in the middle part I see foreign glandular tissue with epithelium, with anaplasia. And in this case I may conclude that this is adenocarcinoma, metastasis of the adenocarcinoma. Hematogenous spread means spreading through the veins, through the arteries, through the blood. Systemic veins that cannot take a part in the hematogenous variant of cancer spreading usually may be involved during the spreading of the cancer from limbs, head, neck, pelvis into the lung. Portal vein system usually involved during the cancer spreading from the bowel, spleen, pancreas, and into the liver. Pulmonary veins usually may be involved during primary lung cancer, metastatic growth in the lungs through the left side of the heart into the systemic circulation. Arterial spread during kidney and renal, bone, limbs, and uterus cancer into the lungs. And either we know about retrograde spread. So this is hematogenous dissemination of different variants of cancer into the target, let's say target organ. Cancer large bowel may spread through the portal vein to the liver, in the lungs, in the brain, bone, and kidney with adrenal gland, like secondary organ for distant metastasis. This is liver with a lot of metastasis into the liver parenchyma. You can see this nodular appearance, whitish color of the secondary metastasis, secondary tumor. So we have primary, right, and secondary tumor that is a result of metastasis. And the third variant of tumor spread is spread along body cavities and natural passage. We know transcelomic spread through the serosal wall of the coelomic cavity. We know spread along epithelium light surface, spreads via cerebrospinal fluid and due to implantation. How can we set correct diagnosis of the cancer? We may completely due to complete excision of the material of tumor, or as a result of the biopsy, final aspiration, or cytologic smears. For diagnosis, we use not only routine histological technique, but also we can use immunohistochemistry. These methods were very helpful in confirming the tissue of origin or of metastatic or poorly differentiated tumor. And this technique uses monoclonal antibodies that are specific for cellular components. For example, in this case, we can see neoplastic cells in the tissue. This cancer infiltrate surrounding tissue, but we don't know exactly what about the origin of these cancer cells. For this reason, we use immunohistochemical reaction with TT41, specific marker for the lung cells, and in this case we see prominent expression of this marker. This marker is positive here, and how do I know it? Because of brown coloring of the stained cells, and I may conclude that in this case I work with non-small cell lung cancer. But also we know a lot of different other very useful antibodies, like S-STOF for S100 for melanoma and neural tumors, actin, CD markers, estrogen receptor, intermediate filaments, and others. So a lot of different markers may be really useful for the cancer diagnosis. Also, we have to say about serum tumor markers like alpha-fetoprotein, beta-human chorionic gonadotropin, calcitonin, carcinoembryogenic antigen, CA125, CA99, and placental and alkaline phosphatase. All and prostate-specific antigen, certainly. All these markers that you can receive from the serum very useful for different malignancies and diagnoses. Grading and staging of the cancer. Grading is defined the degree of anaplasia and rate of growth. And we know for grades, for different entities, we use different grades. Sometimes we use only 3 grades, sometimes it can be 4, according to the amount of anaplastic cells. Staging means extent of spread of the tumor within the patient. When we are talking about staging, we use T&M staging, where T means size and level of invasion, local invasion of the tumor, and nodules means involving of the lymph nodules, and M, metastasis, means presence of distant metastasis. For example, we can receive such combination like T2 and 3 and M palm. What does it mean? That, for example, mean that tumor invade muscular layer of the, for example, bladder's wall. You recognize 3 positive sentinel lymph nodes, regional lymph nodes. Positive means with presence of metastasis in the lymph nodes, and M palm means that you even can recognize distant metastasis in the pulmonary system in the lungs. So grading answer on the question how differentiating are the cells. Staging answer on the question how much anatomic extension. Honestly speaking, both these descriptions are very important for the future treatment, prognosis, and quality of life of our patient. And answer on this question may gives only pathologists. Effects of tumor on the host we name like paraneoplastic syndrome. We know that our tumor may be responsible for the hormone production, for the bleeding or infection, or such acute symptoms like rupture, infarction, metastasis, or cachexia. So, if our patient has some of these complaints or complications, you must be aware and must be ready to find somewhere presence of the cancer. So you have to make a check of your patient and be attentive. Paraneoplastic syndrome characterized by endocrine changes, nerve or muscle changes like myasthenia, changes in the skin, bone, joints, vascular transformations, hematological changes, and renal injury. So if your patient presents with any of these conditions, should you always suspect an underlying malignancy? Yes, sure. Often the term paraneoplastic syndrome is used synonymously with ectopic endocrine hormone production. So this is endocrine part of paraneoplastic syndrome, so you can see that different cancer may be responsible for different changes in the hormone production and characterized by presence of Cushing syndrome, hypercalcemia, hyperglycemia, and different other variants. Thank you for your attention. Don't forget to subscribe on our channel. Good luck!